Welcome. Good afternoon, everyone, and thank you for joining us today for this webinar, Assessing Nutrition Status in Infants and Young Children, Laboratory and Physical Assessment Strategies. My name is Anushree Algotar, and I will be your first speaker for this session today. Before we get started, I would like to thank ByHeart for supporting this webinar today. Also, please note that a link to today's handout is posted in the chat. You can access the chat function at the bottom of your Zoom player. Please also keep in mind that there will be a question and answer period following the presentation. Questions can be submitted at any time by using the questions function at the bottom of your player. So let's get started. Assessing nutrition status in infants and young children. And we're going to focus on the laboratory assessment part for this first session. I have no financial disclosures or conflict of interest associated with this presentation. Our learning objectives for the initial part of this webinar will be to understand the utility of visceral proteins for the assessment of nutritional status, and hopefully we can identify other biomarkers that may serve as indicators of nutrition in children. While it is well known that malnutrition results in poorer clinical outcomes and increased hospital costs, identifying it has been challenging, mainly due to a lack of uniform definition. Studies have noted a wide range of reported prevalence of illness-related malnutrition from 6 to up to 51% in hospitalized children. The 2013 landmark publication by Mehta et al. As part of the ASPEN Multidisciplinary Working Group has paved way for a new era in the diagnosis of pediatric malnutrition. Malnutrition was defined as an imbalance between nutrient requirement and intake, resulting in cumulative deficits of energy, protein, or micronutrients that may negatively affect growth, development, and other relevant outcomes. ASPEN Multidisciplinary Working Group defined malnutrition with emphasis on 5 domains of anthropometric parameters: growth, chronicity of malnutrition, etiology, and mechanism or pathogenesis, and developmental or functional outcomes. With this landmark publication, focus has moved towards efforts to uniformly diagnosing malnutrition in various settings. Assessment of nutrition status consistently across disciplines is important. Utility and interpretation of lab tests for this purpose will be the focus for this section. An ideal lab marker should be sensitive, specific, have a short half-life, and a small pool of distribution. It should be easily and inexpensively measured and should respond to changes in nutrient intake. It should ideally be not affected by other disease processes. Let's just say that one marker that fits these criteria is difficult to find. Historically, albumin and transferrin levels were recommended as markers to identify malnutrition and became highly utilized as a metabolic assessment tool of nutrition. Subsequently, pre-albumin emerged as a more sensitive marker due to its shorter half-life and became the preferred lab marker to assess nutrition status and also response to nutrition interventions. Retinol binding protein, or RBP, is a visceral protein with the shortest half-life, but it is more difficult to measure and is affected by several factors. We will focus our discussion today on albumin and pre-albumin, as these are the most commonly utilized lab markers. Serum albumin. Albumin is synthesized mainly in the liver and is the most abundant human protein in the human serum. With a half-life of about 14 to 20 days, it has long been touted as a marker of chronic nutritional status. Its primary function is as a carrier protein and also helps to maintain oncotic pressure. Its serum concentration is reflective of its synthesis, degradation, losses, exchange between intra and extravascular compartments. Thus, the changes in albumin are affected by multiple factors, and hence serum levels are not always reliable, especially in the presence of inflammation. A quick review of albumin synthesis and degradation is brought together in this flowchart. As you can see, decreased synthesis may lead to lower levels, and this may be seen in not only in malnutrition, but also in liver disease and inflammatory conditions. Albumin is further secreted into the plasma and is distributed both intravascularly and extravascularly. Degradation occurs predominantly in skin, muscles, kidneys, as well as liver, which can lead to lower levels in infections, inflammatory conditions, neoplastic conditions, in addition to malnutrition. Albumin losses can decrease levels as well, which can be seen with renal disease or with protein-losing enteropathy in gastrointestinal disease. Utility of albumin as an independent biomarker for nutrition is poor. More than 50% of the total body albumin pool is located extravascularly. As such, serum levels may not be completely reflective of status. Redistribution between the extravascular and intravascular space occurs frequently. This distribution is affected by the infusion of large amounts of fluids, as may be the case with critically ill patients who need fluid resuscitation. The majority of changes in albumin are likely due to this redistribution response to many factors. For example, it is falsely high in dehydration. Because very little of the albumin pool is comprised of newly synthesized albumin, protein intake has very little effect on the total albumin pool on a daily basis. Albumin is considered a negative acute phase reactant and is influenced by several other factors. Let's talk about pre-albumin. Pre-albumin is the other visceral protein used as a lab marker for nutrition. It is also known as transthyretin, as it functions as a transport protein for thyroid hormone. Majority of the pre-albumin is synthesized by the liver, and hence decreased synthesis is seen in liver dysfunction, partly catabolized by the kidneys, and hence levels may be increased in renal failure. Studies have noted serum pre-albumin levels of less than 10 grams per deciliter are associated with malnutrition. The shorter half-life and smaller body pool size of pre-albumin make it a more favorable marker to detect acute changes in nutritional state historically. It has been touted as a marker of refeeding, as it has shown to increase per day when adequate nutritional support is provided. However, it is also affected by multiple factors, and its utility as an independent marker of nutrition needs to be evaluated in specific clinical context. This is a summary of the changes in pre-albumin level in different situations. Levels decrease with decrease in synthesis, as seen in starvation, liver disease, dialysis, nephrotic syndrome, hyperthyroidism, and hyperglycemia. Conversely, corticosteroid use of non-steroidal anti-inflammatory drugs, and oral contraceptives may increase pre-albumin levels. It is also seen to increase in renal failure and renal tubular damage. Pre-albumin currently has a controversial use as a nutritional marker by itself, and perhaps may serve as a complement to anthropometrics, physical exam, and history. Inflammation significantly affects visceral protein levels. An acute phase response is seen in acute as well as chronic inflammation. And proteins can be classified as positive acute phase reactants or negative acute phase reactants based on whether they increase or decrease in response to inflammation. Several factors lead to decrease in negative acute phase reactants. Hepatic reprioritization of proteins, redirecting protein synthesis to promote ideal immune response, is considered one of the most important factors. In addition, increased capillary permeability and increased tissue catabolism with renal and GI losses affect this as well. As you can see, serum albumin and pre-albumin are negative acute phase reactants. Nutritional assessment using lab markers that are influenced by inflammation is particularly challenging when attempting to diagnose illness-related malnutrition, which is based on the 5th domain definition recommended by ASPEN. Inflammation is a key component in the definition of illness-related malnutrition. The point to stress here is that there is an association between inflammation and malnutrition, specifically illness-related malnutrition, and fluctuations of serum proteins are seen in inflammation. However, there does not seem to be an independent association between visceral proteins and malnutrition. What about non-illness-related malnutrition? Muscle dysfunction, weakness, or loss of lean body mass are associated with malnutrition. There is a common misconception that serum albumin and pre-albumin are markers of protein and muscle mass in the body. The evidence is weak for using serum albumin or pre-albumin as a marker of malnutrition in non-inflammatory states such as starvation. Studies have shown that these protein levels in malnourished but otherwise healthy patients do not decline until extreme states of starvation, when their body mass index falls below 12, or if the duration of malnutrition or starvation is prolonged over 6 weeks. Similarly, albumin levels are found to remain normal until the caloric deficit is obvious clinically. Thus, dietary intake correlates very poorly with visceral protein levels. Visceral proteins have not been shown to be sensitive markers of energy and protein intake adequacy and are not recommended for use in diagnoses of protein energy malnutrition. As noted earlier, levels may remain normal until late stages of poor intake. There are no recommendations to use these as guide for therapy. Evans et al. Note that normalization of serum albumin and pre-albumin levels may still have value, however, in monitoring of recovery. But it should be noted that normalization of these levels may indicate several things, such as the resolution of inflammation, the reduction of nutrition risk, a transition to anabolism, and potentially a lower calorie and protein requirement. Visceral proteins may have a role in nutrition risk assessment. Nutrition risk is the risk of developing malnutrition or the risk of poor clinical outcomes if the nutrition support is not provided. Decline in serum albumin and pre-albumin levels are specifically regarded as inflammatory markers associated with increased nutritional risk. Several studies have shown that hypoalbuminemia is associated with increased surgical risk, increased postoperative mortality, and associated with surgical site infection. These visceral proteins may be useful in identifying patients at risk of poor outcomes and indications for nutritional support. There are recommendations to delay surgery to allow for nutrition support if these risks are identified, unless, however, the surgery itself is aimed at resolving inflammation that may be causing lower levels of these proteins. As such, levels need to be interpreted in context of specific clinical scenario. Quick recap here. Albumin, pre-albumin are historically used as biomarkers of nutrition. In addition to malnutrition, they are low in inflammatory states as negative acute reactants and are affected by several other factors as well, making them unreliable. CRP is a positive acute phase reactant and sometimes may be helpful to determine declines in visceral proteins in the context of inflammation. Here are some of the pros and cons for use of these proteins as biomarkers. Albumin can be easily measured, is relatively low cost for measurement, it's reproducible, and is a good predictor of surgical outcomes. However, it's not reliable as levels decrease in several disease states and inflammation. Pre-albumin is preferred due to a short half-life, and thus changes can be measured sooner. However, it is still unreliable as an independent marker of nutrition. So this brings us to what the current nutrition screening recommendations are, recommended tools are. Once again, citing the ASPEN article by Evans et al., recommended potential nutrition assessment and screening tools are summarized here. Most of these tools include some parameter indicating weight loss or impaired intake. Most of these tools do not include visceral proteins as one of the parameters. Serum albumin is included only in the perioperative nutrition screening tool, where it is utilized as a marker of surgical risk for which we have good evidence. What next if not labs? Imaging and body composition assessment tools and techniques are being studied extensively and have emerged as newer ways of nutrition assessment. These include bioelectrical impedance techniques, which help measure fat and fat-free mass, DEXA scans that help measure fat-free mass, lean mass, as well as fat mass. Ultrasound, CT scan, and MRI techniques can assist with measurement of skeletal muscle mass and adipose tissue. There is increasing recommendations to use these techniques to assess body composition. However, there are few limitations, mainly with widespread availability, standardization, and at times validity in relevant clinical scenarios. Nevertheless, these modalities are seen as potential emerging biomarkers. Wells et al. In their review consider body composition assessments to have several potential benefits. These could be used to monitor disease progress, monitor treatment efficacy, tailor nutrition or treatment, monitor body fat, and potentially predict risks or outcomes. Here is a comparison of some of the modalities for use in neonates and infants. As seen here, DEXA calculates fat-free mass and fat mass from bone density measurements. It is a quick and non-invasive method. However, it has a disadvantage that the infant or patient must be still and asleep and requires specific technician and machines, and sometimes overestimates the total body fat. The total body water, air displacement plethysmography, and MRI are other techniques, and so are total body electrical impedance analysis. Air displacement plethysmography is also touted as a quick and non-invasive method and is pretty accurate, but it requires a technician and a specific machine. MRI calculates adipose tissue volume, and then fat-free mass and fat mass are derived. It is also a non-invasive technique, but has the disadvantage of being a lengthy scan and sometimes needing sedation for younger infants that cannot lie still or remain asleep for calculation. This brings us to assessment of micronutrient status. Malnutrition is often associated with micronutrient deficiencies and imbalances and resultant clinical manifestations. Assessment of micronutrient status is especially important when patients are requiring medical nutrition therapy. Deficiencies may be specific to clinical conditions as described in this table. As we see here, for example, inflammatory bowel disease may predispose to deficiencies of iron, folate, selenium, magnesium, zinc, calcium, and vitamin D. Similarly, intestinal failure due to fat malabsorption can have fat-soluble vitamin deficiencies as well as zinc, calcium, magnesium deficiencies. This also is seen specifically with ileal resection, where you can have vitamin B12 deficiencies. This is a good summary table to bring our attention to these specific nutrient deficiencies related to specific diagnoses. However, assessment of micronutrient status is unfortunately not as simple or easy as ordering a blood test. Measuring the mass or quantity of a nutrient in a cell is different from measuring its functionality or quality. It does not matter how much micronutrient exists in a cell or out of the cell if that cell is incapable to functionally utilize that nutrient. There is lack of concordance between concentration of micronutrients in plasma and their amount within the intracellular compartment. Ideally, micronutrient status should be measured both intracellularly and functionally. Acute phase response, or APR, can significantly affect plasma levels of micronutrients. Whole blood and red blood cell measurements are less likely to be affected by this acute phase response as compared to plasma measurements, and sometimes would be a better measurement rather than just measuring the serum or plasma levels. As with visceral proteins, this acute phase response affects serum and plasma concentration as stated. It is proposed that a CRP level be measured to assess for the inflammation with the assessment of micronutrient status. Berger et al. Proposed the following CRP cutoffs in their aptly titled paper, Pitfalls in the Interpretation of Blood Tests Used to Assess and Monitor Micronutrient Status. Iron, selenium, and zinc levels all decrease in the presence of an acute phase response. A CRP cutoff of 10 milligrams per liter is proposed for significant changes. Iron is very sensitive to acute phase response and hence is not a useful marker in the presence of inflammation. Although zinc is a useful marker in the absence of acute phase response, its plasma value is difficult to interpret in the presence of inflammation and conditions that alter albumin levels. Conversely, copper levels tend to increase in presence of inflammation. Hence, these are unreliable as well. Looking at vitamins the same way, most vitamins show decrease in level in the presence of inflammation, with the exception of vitamin B12 that shows a modest increase in the presence of acute phase response. As noted, just obtaining a serum level of micronutrients may not be representative of status, especially in the presence of inflammation. For the purpose of this talk, we will focus on a few micronutrients, starting with iron. Ferritin and transferrin saturation are adequate markers of iron status in the absence of inflammation, but unreliable in its presence. The soluble transferrin receptor is a sensitive indicator of the extent of tissue iron deficiencies, and it appears to be less affected by an acute phase response. Hepcidin is considered to be the best diagnostic tool in the presence of inflammation, but it is not available for practical use currently. Thus, interpreting specific nutritional status by labs alone can be challenging. Similarly, with other micronutrients such as folic acid, B12, copper, we have the similar challenge. For folic acid, the intracellular option of RBC folate is preferred over plasma levels. Alternative indicator is a plasma homocysteine, which is sensitive, but the effect of inflammation on it is currently undetermined or not established. When talking about vitamin B12, and MMA is the most reliable parameter, but it is affected by renal function, age, and we don't have a specific established cutoff as such. Holotranscobalamin, or an active B12 level, may be better in terms of sensitivity and specificity than the serum B12. For copper, the RBC copper seems to be unaffected by an acute phase response, but further research is required for its practical use. Ceruloplasmin seems to be useful in severe deficiencies. However, it is affected by an acute phase response, immature liver function, and estrogen. Free copper indicates the albumin-bound copper, which has more reliability, but we need further research to confirm its practical use. Studies have shown that the risk of zinc deficiency increases substantially in subjects that are at high risk of malnutrition. The assessment of zinc status, again, is challenging as only a small fraction of body zinc is circulating and most of the zinc is bound to albumin. Therefore, albumin deficiency makes interpretation of serum zinc very difficult. And it is likely that zinc deficiency in subjects at risk of malnutrition remains unrecognized most often, and it should be considered in protein calorie malnutrition, poor intake, excessive losses, and those requiring supplemental nutrition. It's a similar challenging situation with multiple other vitamins like vitamin A, vitamin C, vitamin K, vitamin E, and vitamin D. Vitamin D is currently the best marker of nutritional status in the absence of inflammation. It is, however, strongly affected by inflammatory response. When assessing for vitamin D deficiency, a comprehensive assessment is usually helpful. Levels of calcium, phosphate, alkaline phosphatase, parathyroid hormone, as well as clinical and radiographic findings all help together to build a complete picture for appropriate diagnoses. Let's conclude this first part of this webinar by discussing some clinical scenarios where biomarkers have a specific role. Refeeding syndrome. So refeeding syndrome is historically defined as a range of metabolic and electrolyte alterations occurring as a result of the reintroduction and or increased provision of calories after a period of decreased or absent caloric intake. Hypophosphatemia is the hallmark finding. However, hypokalemia and hypomagnesemia are equally significant. Thiamine deficiency may also manifest as a result. Incident and risk assessment is challenging given the lack of a consensus definition. ASPEN, a working group, has suggested the following consensus definition: a measurable reduction in levels of one or any combination of phosphorus, potassium, and or magnesium, or the manifestation of thiamine deficiency developing shortly after initiation of calorie provision to an individual who has been exposed to a substantial period of undernourishment. So as we stated below, since we don't have a uniform definition, the incidence and assessment of risk is difficult, and currently the literature is sparse to be able to recommend routine use of biomarkers for clinical use of predicting refeeding syndrome. There are certain factors that are implicated as predisposing factors based on which this risk stratification has been developed as in the table before you. It should be noted that in addition to biomarkers, mainly decreased levels of serum potassium, magnesium, and phosphorus, anthropometric measurements, energy intake, and comorbidities are also taken into consideration. So this is an example of a clinical scenario where biomarkers are utilized to predict risk. The next clinical scenario that we will discuss here is intestinal failure and short bowel syndrome. Intestinal failure in children is defined as an insufficient functional intestinal mass needed to adequately digest and absorb nutrients and fluid required for adequate growth and development. Short gut syndrome is one of the most common causes leading to intestinal failure, and is defined as a reduction in the functional bowel length due to surgical resection. Micronutrient deficiencies occur in intestinal failure mainly due to malabsorption, increased losses, and loss of functional gut mass. Micronutrient monitoring is undertaken mainly as a means to guide provision of supplemental nutrition while attempting to replete the deficient nutrient. Overload is a possibility when providing supplemental nutrition, and it needs to be monitored as well. Here is a brief summary of micronutrient deficiencies, as well as overload syndromes that need to be taken into consideration with this specific population. So this is a specific clinical scenario and an example of micronutrient monitoring utilized for provision or monitoring of nutrition intervention. The next clinical scenario that we'll briefly touch on is chronic and end-stage liver disease in pediatrics. This is an interesting clinical scenario in the context of malnutrition. Malnutrition in liver disease is common and is an independent predictor of outcomes. It can be multifactorial, related to poor intake, altered nutrient metabolism, maldigestion, or malabsorption. Early identification of malnutrition and nutritional deficiencies is crucial, especially in pre-transplant patients where there is an emergent need or important need to optimize nutrition. Fluid overload and organomegaly lead to a lot of challenges in this clinical situation. As such, an appropriately measured length or height proves to be the more useful anthropometric parameter as compared to weight, given the ascites, organomegaly, or fluid overload. Mid-upper arm circumference and tricep skin fold thickness are less likely to be affected by fluid overload and are recommended to be performed serially as an assessment of nutrition in this population. This is another population where functional assessment has proved to have some utility. And an example of this is hand grip strength, which can provide estimation of muscle function. This can be performed at bedside and needs to be studied further for its utility in practical use. Imaging modalities such as DEXA, body bioelectrical impedance analysis can be useful, but these are also affected by the fluid status. Assessment of sarcopenia, which is defined as severe muscle depletion, may be also utilized in this population. Again, there is need for further studies for this to be used in the practical clinical areas. Ultimately, the utility of visceral proteins in this population is variable and limited, as the levels are unreliable and may be decreased due to decreased synthesis or excessive losses. So a careful nutrition-focused physical exam is what is recommended at each visit to help with the assessment of nutrition in this population. Here is a table, again, summarizing the approach to lab monitoring in pediatric cholestatic or end-stage liver disease. Most of these lab assessments have some limitations, mainly related to the fluid overload and redistribution of fluid. And these need to be taken into consideration when you're monitoring for micronutrient status and malnutrition. This brings us to the end of the first part of this webinar, and we'll just go over the concepts that we discussed as a summary. So the ideal marker of nutrition should be sensitive, accurate, reproducible, relevant in health and illness, and applicable to patients at bedside, and should also be cost-effective. An independent marker fitting this criteria currently does not exist. Serum albumin and pre-albumin are not components of currently accepted definitions of malnutrition. These visceral protein decrease in levels in the presence of inflammation, regardless of underlying nutritional status. And these are recognized as negative acute phase reactants, which are more associated with nutrition risk. The normalization of these visceral protein levels may have some value in monitoring of recovery. An acute phase response needs to be considered while measuring micronutrient status as well. Micronutrient assays may involve alternative functional options that better reflect status. Imaging and body composition assessment are emerging modalities for assessment of nutrition status, but these too have some limitations. Ultimately, a physical exam and functional assessment are important in nutritional assessment and screening. And this takes us to the next part of our webinar with Sarah.
Hi, thank you, Dr. Algotar. That was some excellent information. I'm so excited to be able to utilize some of that in practice and on my team. Let me get myself going here. My name is Sarah Vermilyea. I am going to be talking about using nutrition-focused physical exam to evaluate nutrition status in children. I work at an intermediate care facility in Cincinnati, Ohio called St. Joseph Home. And I want everyone to know that the people that are featured in this presentation, there's only a couple of them, but they do have signed photo releases on file. And I do not have any other disclosures. Today, the objective is that you all will be able to describe how nutrition-focused physical exam contributes to understanding a child's nutrition status and to propose one way to integrate or further integrate NFPE into your practice. So like Dr. Algotar did a great job of showing how labs are sometimes helpful and in different situations. Another big part of being a pediatric dietitian and doing a nutrition assessment is, of course, using metrics to monitor growth. We have weight, length, height, head circumference, mid-upper arm circumference, and a little bit less often tricep skin fold. A lot of these should be really standard practice right now. And what my point to bring towards this is that we want to use accurate and meaningful measurements only. For example, you might have a child who has a lot of edema and fluid on board. You can measure an accurate weight that's reflecting that fluid. It's not as meaningful from the standpoint of how you're going to be basing nutrition interventions. It's meaningful to be able to track when that fluid is going down, but that's a different situation. Those numbers should definitely be documented. In my population that I work with right now, a lot of times a length or a height measurement that's accurate and meaningful is not possible. We have lots of people with scoliosis, kyphosis, tendon contractures, so I'm just unable to get any measurement that is meaningful. And instead of putting a number down that maybe I get with a tape measure on a segmental type measurement, I'm actually going to just write why the measurement is not effective or helpful. This table just speaks towards some of the benefits of some of the anthropometric measures and limitations. And I always like to make a plug in regards to anthropometrics towards the Z-score usage also. The benefit of Z-scores is you're able to describe the individual state and trend. The drawback is that caregivers and some healthcare providers are still less familiar with this concept, whereas the percentiles, the benefit is that it is more of a familiar concept and people are used to the language of those percentiles. There is some confusion still of percentile versus percentage, and there is definitely some education required, especially for first-time caregivers, that we're not trying to get to 100%, that is, you know, where the growth curve comes into play, and so still some education there. And then the percentiles also don't provide the words or numbers to be able to describe changes in the percentile for children who are off the charts. And we're definitely utilizing appropriate age and sex-specific references. Here's kind of a pictorial of percentiles and Z-scores. So we have here a 13-year-old female, and you can see that the weight, the stature are both listed as 0 percentile. This is using the PD Tools, very helpful resource to make these tables. And the BMI for age is listed at the 6th percentile. A couple of years later, this is that same person. Their weight, their stature is still 0%, and now their BMI has dropped to 0 percentile listed. You can see that they have had a couple of kilos of weight gain. Their stature has grown. Something's not keeping up. We can see that much. And then over here to the right is a little snippet of a growth curve that's weight for age. Here you can see that weight gain reflected. It's a little hard to tell. Is it getting closer to the curve? Is it not? I also want to mention that you need to please keep in mind that my patient population is not the standard pediatric typically developing. So I don't want you to get stuck on the fact that these numbers are just so far off the chart. But this is my world of needing these numbers to describe better. So there we can see the Z-scores. So that weight for age Z-score started at -8, and now even with a couple kilos, it hasn't kept up. So that Z-score is -11. You can see that the height was keeping up and that the BMI has decreased, which is helpful information. So instead of the 0, 0, 0, I can actually document change and if we're moving in a desirable direction or not. If you're looking for tools for Z-scores or percentiles, the PD tools is kind of where it's at right now. This is just a screenshot of the first page showing you that they have WHO and CDC calculators that will show percentiles and Z-scores similar to what I just showed. They have mid-upper arm circumference and some skin fold options as well. So what is a nutrition-focused physical exam? This is another part of nutrition assessment. We have labs, we have anthropometrics, of course we have a lot of other things, interview of the family and the caregivers and the child, and then we have a physical exam. So this is a hands-on assessment. It's specific to nutrition-related components. It does not replace the exam of other medical professionals. If I think about going into an office visit as a patient or into the ED, if that was needed, a lot of people are coming at me with stethoscopes and all different kinds of things. They're all doing exams that are specific to their needs and what they want to see from the patient. And it's the same for us. We're not replacing someone who is listening for signs of pneumonia, but we are really focusing in on anything the body can tell us about the nutrition status of this person. And it's the nutrition-focused physical findings is actually a component of the nutrition care process. This is a systematic method to providing nutrition care that was developed by the Academy of Nutrition and Dietetics about 20 years ago. It was implemented and it has been adapted over time. It's just showing that the physical exam and findings continues to be very important. I'm going to pop right in here right away with NFPE via telehealth. This has been such a stressful and difficult time wanting to do these hands-on assessments and then being thrown into this world of so much telehealth. So I don't want people to get caught up that they have to throw this whole thing out because it can't be hands-on. If you can see in the reference down here, Aspen has this practical tips for performing nutrition assessment remotely via telehealth. And there's a link on the reference page that you can actually get the website for that. It's a really helpful document. I pulled a few things off of it specific to NFPE and how that can be at least something is better than nothing type situation. So observe what you can on the screen, asking for the child and the caregiver's assistance with positioning the body to the camera. There's a lot you can do actually to move around and see different parts of the body, and definitely ask for their participation in that. Teaching the patient how to assess some areas. If something is really hard like a bone, they can tell you that. If it's kind of softer, like some squishy cooked meat or muscle, they can tell you that. There's information. They can learn how to pull down their lower eyelids so you can see that conjunctiva inside their lower lid. If they get to really be involved in their care, which is kind of neat. Ask questions about whether the child or the caregiver has noted any changes. Has there been more hair coming out in the hairbrush? Are you having to loop that hairband more times around a ponytail? Are clothes fitting differently? Looking at pictures from a couple of months ago, is the face more drawn or kind of a different color to it? Those are some of the questions that you can ask. So why are we so focused on physical exam, and really what does it bring to the table? From my standpoint, I know the dietitians, we just tend to be amazing interviewers. We know so many questions to ask. We work with such a delicate population and topic of body habitus and caregivers' care and nourishment of their children. We have to come at these questions so many different ways to get the answers that we're looking for. And if I can just touch and see the person and get that information right back to me without kind of having to go this telephone of interpretation through multiple people with different mindsets on what I'm asking, it's just such a great benefit to have something that I can do and get an immediate kind of answer on. And then also, here's a situation where you have maybe these anthropometrics that have come through. You don't know this person yet. Their weight is 0 Z-score. That's looking fine. Their stature seems like surprisingly low at almost -2. And combined together, that's putting the BMI elevated. So before you even go and see this patient, you might be thinking like, oh, I don't know, we need to find out what's going on with stature. If that's actually as appropriate, then the weights may be too high. And you might already have some ideas going in your head on what you're going to do here. Then when you go and you meet with this person, you'll have someone like this wonderful person that I get to work with, and you can see probably right away that that stature measurement is going to be questionable. With scoliosis and tendon contractures, it's not possible to obtain a meaningful measurement of height on this child. So that takes away the stature, and as well the BMI is kind of thrown out. So now we have the weight, and then further into the physical exam, you might be able to see to her right side, she has that curve there. Sliding a hand back there, there's no contact between her back and the bed, and putting a hand on top of her stomach, there's a much smaller amount of space than you might think just looking at her. So another example of how getting those hands on really can change the picture. Another example is here's a 7.5-year-old female with a pretty impressive weight and height that are pretty notably above standard for the Z-scores. And then that puts the BMI up into an overweight status. Going into this is a situation where you could even be talking to this family and this child in the room. Maybe it's wintertime, they have on a lot of clothes, you don't really know what's going on under there. And if you don't take the time to get to the skin and get your eyes and your hands on the situation, you might miss some important information. So here's a child who has pretty good musculature and definition. You can even see kind of that Y cut of her back, and she's really active in gymnastics and swimming. So her muscle mass is quite a bit higher, and that might change your interventions once you see that versus just going with this information on the table. So nutrition-focused physical exam, I'm not here to explain how to do it. We're talking about what it is and how to integrate it. But it is like a head to toe exam, and you can do it in any order. We just say head to toe because it's kind of a handy way not to forget anything. And 3 of the areas in that exam that we're looking at from a kind of a macronutrient perspective is the fat stores, the muscle mass, and fluid status. So this is a combination of some aspects of this reference that's listed down here. In the reference, it's more specific. You see this is your sign of concern. I'm just kind of giving an example. So some of the sites that you're looking at for fat stores is around the eyes and the upper arms, the ribs, and the lower back. So some notable signs of concern in those areas with that really hollow look around the eyes, a small amount of fat to squeeze in the upper arms, like differentiating from the muscle, and then really apparent depressions between the ribs. For muscle mass, some of the areas are the temple, around the clavicle, along the back, the scapula, and the interosseous muscle. And some notable concerns there would be like a real big scoop here, a hard temple, prominent bony protrusions, a neck, shoulder, arm that looks like really squared off and not sloped at all with muscle. For fluid status, we're looking for both edema or dehydration. So looking at the actual eyeballs and other mucous membranes, that's the shape of the eyeballs, skin, the ankles, the bottom of the feet, maybe if it is an infant, the sacrum, if it's someone who's been spending a lot of time lying flat in bed, or the lower legs, if it's someone utilizing wheelchair or walking. Looking at micronutrients again, these are some of the sites we're looking at, a grouping of signs you might see, and some possible nutrients of concern. So this is when we're looking at the body. We don't really have anything in particular we're looking for. We're just doing a full comprehensive exam. We're looking at skin, the nails, the tongue, and anything that we're noticing that is not what we're expecting or is out of the ordinary. We're documenting that, and then we're taking that information to find out what are the possible nutrients of concern. I don't expect you to be able to go through all of those levels right away. That's great if you can, but I sometimes need to be like, what is the what is the bruising of the skin again? And that's where you utilize these resources. Here's a couple of examples. If you come across someone and you're noticing hair loss, bilateral edema, and a decrease in muscle mass, that can be compared to the last time maybe that you saw this person, or per the report of the patient or the caregiver, or even compared to the documentation of the person who did a nutrition assessment previously. I found that amazingly helpful, is now that we're having more standardized documentation and language, that I can actually take my subjective exam and notice differences from someone else's. So here we might be considering protein deficiency. Once you found your signs and you're considering what is wrong, what deficiency it might be, the next step might be to just double check, does that make sense? So is this person not eating a lot of protein? Then that makes a lot of sense, and you can go ahead and start working towards increasing the protein intake. However, if this is a person who reported to eat a lot of protein, this is not making a lot of sense. This is where you pull in your interdisciplinary team and you really put your heads together. Was there an acute illness recently that resulted in poor nutrition status? Is there some other medical component going on? Or is there maybe even a social concern that the food security isn't what it seems? Another situation, seeing some waxy, crusty areas around the lips, the eyes, and the nose. It's really important not to assume that skin concerns are due to like poor hygiene or maybe even acne, that type of thing. A lot of nutrient deficiencies and even toxicities can manifest in the skin. So taking a good close look at that. If you notice or have reports of slow wound healing or a change in sense of taste, we're considering zinc deficiency. So again, if that makes sense from with other information that you know, that's great. You can also reference back to Dr. Algotar's talk about what lab values might be effective and helpful in that. And then you can also then just supplement as you need. Third example, so we having that pale conjunctiva of that inner lower eyelid, a pale complexion, and maybe some ridged or concave nails. These might lead you to consider iron deficiency, might also lead you to consider folate or vitamin B12 deficiency. And this is again a reference back to Dr. Algotar and what are the levels of labs that you would want to be considering. On the opposite side, so that was all nutrition-focused physical exam when you're just looking for anything you can find. Doing the NFPE with a known nutrient of concern is a different situation. So it's kind of in addition to that. So perhaps you have a patient with known food insecurity. You can also kind of see like their diet is really highly based on carbohydrates. They're not buying eggs, meat, milk. It's not a vegetarian diet. They haven't incorporated lots of beans and legumes into their diet, and you have concerns for protein intake. Maybe someone is on long-term omeprazole and is not using a citrate-based calcium supplement. That could be a concern. A picky eater who you don't see any source of iron in their intake history, and then inflammatory bowel disease, liver disease, and also seizures medications can contribute to some actual like specific nutrients of concerns. So if you take this turquoise column, and then we're going to flip it over here, so turquoise column of the nutrients of concern, then you can go and look at your reference on what NFPE signs might we be looking for. So say we have that, go back to that picky eater, and we don't know where their iron is coming from. Before I see that patient, or maybe after I've come out of the room and I'm just thinking through where's the iron coming from, I'm going to look and say like, okay, eyelids, hair, pallor skin, nails. Did I do that? Do I need to go back into the room and maybe grab those eyelids? This is like a specific thing. I want to make sure I don't miss looking at these areas if other things are pointing me towards an iron possible deficiency. And then this leads us kind of more to the correlation between the NFPE and the lab testing. So a lot of things come into the nutrition assessment and diagnosis and interventions for nutrition care. But these are just two aspects of it. So if the physical exam is normal, the labs that you have access to are normal, there may still be something going on, and you're going to identify that hopefully in another area of the assessment. But looking at these two things, I would have a low concern for a deficiency at this time. And if the NFPE is normal, but you have some altered labs, like maybe this is a vitamin D level is low, but you're not seeing any of that, ask more questions, see again if it makes sense that that could be a deficiency, and then consider intervention if still indicated. On the flip side, if the NFPE is altered but the labs are normal, this could be like iron, hemoglobin hematocrit still normal, but then you're seeing some signs of iron deficiency on NFPE. This is where you can go, and if there's some labs coming up, you can try to get some more of those iron-related labs on there, and then intervening if appropriate. On the flips, and then if the NFPE is altered and the labs are altered, then you can feel pretty confident that you are on the right track and that this is an intervention that would be needed. So integrating NFPE into practice, I feel like there's about three kind of group logistics that get into the way: patient, facility, and personal. So I'm going back up to that patient. So first of all, the patient not being present, we kind of talked about that, utilizing that telehealth guide and the observe, teach, and ask concept. Another patient-related logistic is positioning. Sometimes we can't get the patient into the optimal positioning status, and if we're not able to, just work with what you have. Don't throw the whole thing out the window because everything isn't exactly how we want it. Maybe they're having pain, maybe they're not able to get into that position, maybe you don't even have time to try to get them into the position, but just do what you can and you can still definitely get some helpful information. Facility logistics, the number one that I hear is time for this exam. So just starting with one nutrient or one body part. So if there's a common deficiency in your population like iron, start by checking one or more of those body areas that are commonly impacted by iron. If you're in an interdisciplinary clinic, ask to sit in the room while another provider is interviewing. This can maximize your time and the questions and the observation that you get to do. Some people get hung up on getting access to the equipment that they would really like to use. If you don't have the equipment, just skip it. Focus on those body areas where you don't need equipment. Keep advocating for access or better access to what you need. But once again, just get started, get in there and do what you can. And then there's adjusting the electronic health record templates to include nutrition-related findings. So my idea for this is to obtain some examples for your EHR team if you don't have it. And if possible, please don't reinvent what's done before, but I know sometimes that is just simply required. Some personal logistics is getting training and maintaining training. My ideas here is just to ask and seek. Ask your employer for funds to attend training. I know that's kind of like, haha, where are the funds coming from? But if no one is asking, it's not going to be valued and it's never going to come. So you can also consider accessing some of the resources listed at the end of this presentation. Some of them still cost money, but some are more or less, and they can be a starting point on where to point the people in your facility as well. Dietitians want to have a lot of experience before they jump into doing something with patients, but it doesn't work that way, unfortunately. We just have to start. The skill and the comfort is going to come. That comes also with setting your expectations and being patient. Just add one goal at a time and keep at it. I like to recommend putting a monthly reminder on your calendar, just NFPE. So if you pick, like, you're going to look at everybody's nose, and in a month your reminder comes up and you think like, oh, I got that down, let me add another one. Or maybe you think, I did not do that even a single one time. Maybe I'm going to pick something different. Or maybe that's your reminder to check in with the EHR team and see how that build is going. Just something to keep it in the front of your mind. So in conclusion, serum albumin and pre-albumin, as Dr. Algotar was describing, do not serve as valid proxy measures of total body or muscle mass and are not components of currently accepted definitions of malnutrition. A nutrition-focused physical exam is a powerful component of a dietitian assessment. The labs, the history, and the exam combine to tell a bigger picture than any of those alone. And imaging and body composition assessment are emerging modalities for assessment of nutrition status, but like everything else, they have some limitations. Here are the references for my talk, some additional resources that are great, those NFPE training resources. And Dr. Algotar and I want to thank you very much for this talk and being here with us. We've provided our emails here. If we don't get to your questions on the Q&A, you can reach out to us and we'll see how we can help. Thank you so much. And then Dr. Algotar, if you want to jump in with a question.
Thanks, Sarah. That was really great. Thank you for your expertise and sharing that with us. So we have a few questions here. I'm going to go through one or two of them and then let Sarah handle the rest. The first one we have is, sometimes we have trouble getting insurance to cover specialty labs such as serum, vitamin, or minerals. And if we need to limit those tests due to out-of-pocket costs, are there one or two specific ones that you would routinely check? Again, I think this brings us to a point that not one or two lab tests can be independently used to effectively diagnose malnutrition. So I think I would make sure that in these scenarios specifically, we have a more comprehensive assessment, looking at growth chart, looking at the exam. But if there is no sort of inflammatory response associated, I would think some of the common deficiencies that we see would be vitamin D and iron, which we would frequently want to check and intervene. And those are probably what we would consider getting. And Sarah, do you have any other thoughts to that, or?
No, I think that's great. That's great. Mm-hmm.
Okay, I think the next question is for you down here.
Yeah, sure. Is there a handbook for NFPE in infants and children that you would recommend? Yes, if you, I saw that everyone was getting access to the slides pretty effectively. So on the resource list on mine, there is the Practitioner's Guide to Nutrition-Focused Physical Exam of Infants, Children, and Adolescents. That's by ASPEN, and it's really excellent. Specific to pediatrics, of course, the Modarsky and Wolf Pediatric Nutrition Focus Pocket Guide is always on my desk. And all of the ones that I have listed there are really helpful. One of them is adult focused, but it's just getting the basics of what does this look like in a person. So I think that's important too. That's really all we have for questions. So, and our time is up. So we're now at the end of our time. So we'll conclude this program. I would once again like to thank you for joining us today and for ByHeart's support of the presentation. If you missed anything, a recording of the presentation will be available on the ASPEN website within a week. Thank you for joining us and have a great day.
Thank you all.